And we're recording.
Hey everyone, thank you very much for joining us today. I want to get started off by acknowledging that ABI is on stolen land, on the land of the Lkwungen speaking people and those of the Songhees, Esquimalt, and WSÁNEĆ peoples. We talk a lot about colonization these days, and we talk about it as if it was something that has happened in the past and is no longer occurring, but we see it all the time today. We see it in the way that folks who are left homeless and unsheltered during a pandemic have their movements controlled, and how they are decamped and evicted from locations and the subsequent harms of those. We also see it in the shabby land acknowledgements that some of us do, and I've been spending a lot of time working on my land acknowledgements and finding out what it really means to perform a land acknowledgement, and struggling even to find the language, and that in itself is also a result of colonization. And so part of my process is to continuously opt to be a learner in this process and acknowledge that I am flawed in this. And so I'm always open to suggestions for improvements when it comes to performing a land acknowledgement. We also want to make sure that we are acknowledging people with lived and living experience and the role that they've played in the development of training resources, in the development of education resources, in the development of the programs that we offer here in Victoria and abroad. This presentation itself is made possible by people with lived and living experience of drug use, sharing their knowledge and experience with paid educators. Without their generosity, this presentation would be impossible. And in fact, without their generosity, this project would be impossible. As you're going to learn while we go through what the SAFER project is, you'll note that we are making a very concerted effort to move away from tokenistic consultation and engagement with people with lived and living experience, and integrate them both into our service delivery model, but also in the way that we create our project, in the way that we evaluate our project, and in every way that we can possibly do so, because for the majority of times when these projects and interventions are put into place without that meaningful consultation, they're doomed right from the onset, because they don't fit the local context, they don't fit the realities of people who are going to be trying to access these services. My name is Corey Ranger. Many of you know me. I'm a registered nurse, and I'm the clinical nurse coordinator for ABI Health and Community Services. I'm here today to talk to you about the SAFER project, and really happy to be co-presenting with Heather Hobbs, who is more than capable of doing her own introduction.
Hi, everyone. I'm Heather. I am the project manager for the SAFER project.
Why are we all here? Well, it's pretty obvious that the overdose crisis in British Columbia has continued to get worse and worse. When COVID first started, we were under the impression that we would see less fentanyl on the streets because of disruptions to borders, because of people self-isolating and having to quarantine. We expected that there would be more additives in the street supply, like benzodiazepines and other sedatives. But the reality is that we actually saw a large influx of more volatile concentrations of fentanyl and benzodiazepines. Pre-pandemic, the average fentanyl concentration on the street supply was around 8%, and we're now seeing average concentrations around 24%, and the risk continues to rise. Here in British Columbia now, you are in fact 4.5 times more likely to die of overdose than you are of COVID, and yet we still don't get the attention, support, and resources that this crisis has needed for so long. Safe supply in itself has been something that we have been asking for, that advocates have been asking for an incredibly long time, and it actually took a pandemic to get it rolling forward. And that's actually one of the problems with the current approach to safe supply, is that it is done under the guise of a risk mitigation for COVID-19 transmission. It's not as a overdose mitigation, it's actually to reduce people's likelihood of contracting COVID. And that's just one of many things that we need to move away from. Those of you who are unaware, and I'm looking at the list of people who's joined us today, and you're probably all quite aware of this, but this is also meant to be for the broader public as well. What is safe supply? What is here in Victoria we're calling PPRM in some corners. We're also hearing it called pharmaceutical alternatives. Essentially what we're talking about is a prescribed alternative to the illicit drug supply. Safe supply is available in medicated forms for people who use opiates, for people who use stimulants. It's intended also for people who use benzos on the street, and managed alcohol is also another form of safe supply. There's a ton of really important reasons to support safe supply when it's done right, when it's delivered in a model that people can access, when it's done in a way that provides the drugs that people are going to want to actually use. First and foremost, our intent is to make sure that we're supporting people so that there's less overdose deaths, so that we can stem the tide of overdose deaths. We also see that this is a great opportunity to find a step towards decriminalization and less police intervention when we get closer to a safe supply that is actually equitably accessible. Of course, it does reduce COVID-19 risk because there's less people going and having multiple interactions with folks on the street in order to get what they need. It's cost effective. It's a lot more cost effective than engaging substance use through a criminal justice lens. It's about also, as all harm reduction initiatives are, about increasing access to other services, about creating a launch pad so that people can be connected to care and supports and reestablish trust with the health and social systems. And of course, we want to make sure that people are experiencing less stigma, less withdrawal, and should they want, that this is an opportunity for them to seek supports if they're looking for more of them. Safer Victoria, the project that we are engaging in, is a SUOP funded project through the federal government. We have been awarded funding between now and March 2021 in order to develop a flexible delivery model for safe supply. And we'll talk a little bit more about what that delivery model looks like in the future, just coming up. This infographic that's up here on the screen for you is just one of the examples of some of the resources that we developed through the Safer project. And this is about supporting people to help clients or community members or friends gain access to safe supply. And all of these can be made available if you're interested in having access to them. We're more than happy to share them with you. Our Safer project has a couple of different mandates. First, we want to increase access to pharmaceutical alternatives that reduce and prevent overdose, but also that affirms and improves the lives of people who use drugs. Part of our mandate is also to challenge the current risk mitigation guidelines from the BCCSU in order to push back on what drugs are currently available and broaden access to drugs within the current existing legal framework. We're also developing a service delivery model that's grounded in lived and living experience. At this point, safe supply is highly medicalized, and it's being viewed through an addiction medicine model. Safe supply in itself is being offered as a withdrawal management tool. And so what that means is the drugs aren't right, the doses aren't right, and the way in which people are accessing them aren't right. And so what we have been tasked with is to find a different delivery model that's peer and nurse-led, that reduces the unintended gatekeeping that happens from physicians, and it also is grounded in a trauma-informed lens that, as they say, meets people where they're at. And we're also looking to accumulate more evidence for further action. Safer is a bit of a hybrid project because we do a lot of consultation and engagement with people with lived and living experience so that we can actually find out from them what's going to work. I know that sounds like such a ridiculous concept, but we continue to have these shortfallings in public health and in overdose responses where we're not actually talking to people who are going to access these services. So in a little bit, we're going to talk about what the research and evaluation looks like, and Heather will be able to give you a little bit of information about that as well. Safer is also intended to be delivered through a harm reduction model versus an addiction medicine model. And so if you see on the screen here, there's a couple of different ways in which you can view harm reduction versus addiction medicine approaches. In addiction medicine, doses are often too low and clients start to experience effects like withdrawal in the middle of the night. Right now, safe supply is often being offered as a condition of OAT. So people are only being offered their safe supply if they also take methadone or Cadian alongside it, which unfortunately is a bit of a form of coercion with patients, with clients, and it has resulted in some folks not being willing to access safe supply because they don't want to go down the road of methadone or Cadian. They've had some negative experiences in the past. The medications that are provided don't often meet people's needs. For example, currently what's available through the risk mitigation guidelines, none of the drugs that can actually be smoked. And the majority of people who are dying by overdose in British Columbia are people who smoke their drugs. Through the addiction medicine model, there's also a ton of things happening when it comes to requiring urine drug screens. If people miss their doses, then the prescription gets canceled. People being given 7-day prescriptions who are sleeping out in parks, and then they're getting evicted by the city, and we can't follow up with them, and their script runs out, and that just creates more harms. And clients are frequently lost to contact, and then their prescriptions end up being taken away. And what we're aiming to do is to make sure that the client is actually a member of their own care team, and that their needs are identified by themselves through that person-centered approach. And we work with them from that point. We don't make assumptions. Prescriptions are not provided as a means to manage withdrawal, but to actually provide a safer alternative to the toxic drug supply. And that means pushing back on some of the dose ranges and the drugs that are available. We intend to employ a system where peers, nurses, assistants, navigator, and physicians are working together to address the client's needs, and to create a system of follow-up so that folks have someone that they can lean on, that they can contact if their doses are missed or if there's something going on, if it's not enough. And we want to make sure that follow-ups with the care team can ensure that issues with accessing are routinely addressed. And we've seen a ton of issues with accessing over the last month and a half. So those of you who are aware, the end of March, BC Centre on Substance Use released these risk mitigation guidelines. They've since been updated. I think it's called version 1.5 now, that was released in April. These risk mitigation guidelines are not actually guidelines. They're guidance documents. And there's an important delineation to make there. When you talk about guidelines, there's actually some legal connotations in there that they actually have to be followed, which a lot of people have interpreted these guidance documents as a legal document. But in fact, it is not. It is more of a suggestion. It is more of a framework that people can build off of. And by that vein, what that means is that we are actually able to go beyond what these guidance documents state. It hasn't happened a lot, particularly in Victoria. We've seen a lot of people really stick to these guidance documents as if they were a legal framework. But we have a small group of physicians that are working on the SAFER project who have agreed to rewrite their own guidance documents that are going to better meet the needs of people who are at risk of overdose, and based off of some of the great feedback and evaluation that we've already been able to do. So who is on the SAFER team? Well, we have a very comprehensive group, and like we've said before, we're working on grounding it in folks with lived and living experience. So what is the SAFER project? It's a person-centered approach in increasing access to pharmaceutical alternatives. And we want to make sure that participants are engaged in their own care and being able to identify their own needs. Why do we want to do that? Well, that's because it's going to be the way that's going to work best for people. Our team consists of peers and outreach workers with lived and living experience. They are currently the missing links when it comes to service delivery models for pharmaceutical alternatives. And that's a shame, because they're the best suited in order to engage with people, in order to give us feedback on what's going to work for people and what's not going to work for people. And they haven't been adequately integrated into these teams at this point. We also have nurses. Nurses, again, are currently underutilized when it comes to the provision of pharmaceutical alternatives. But for those of you who have been paying attention to the news, there was a great announcement just a couple days ago that nurses will be able to start prescribing pharmaceutical alternatives. If any of you think that that's going to happen overnight or dramatically change anything, then you probably aren't familiar with government processes, because even though they announced it a couple days ago, it's likely that it'll take at least another 4 to 5 months before they develop proper guidance documents and decision support tools and roll out nurse prescribing. So for the interim, we are still working in a system where physicians and nurse practitioners are the primary prescribers for Safe Supply. With that being said, we have a great group of doctors. We've got 5 inner city physicians who are really keen to push back on the existing risk mitigation guidelines in order to meet people's needs, particularly those who are left unsheltered. Our 5 doctors have a ton of experience, span the workflow capacity from PHS to Kool-Aid to AVI, and they really know our clients as well. And they're keen on checking their own assumptions and learning what isn't working, and finding ways in order to be more flexible and maneuverable during this crisis. And lastly, we have an amazing systems navigator. Her name's Katie. I don't know if she's joined us yet today, but Katie is essentially doing all of the behind the scenes work with people in order to address issues as it pertains to the social determinants of health. So it's not just about getting people onto Safe Supply, it's also about the aftercare. What do we need to do so that they don't have any issues accessing the pharmacy? What do we need to do in order to make sure that they have coverage, that they have ID, that they have housing applications in? And that's where the systems navigator comes in.
So in terms of where the team has been functioning over the summer, Corey's been doing a lot of work in partnership with outreach workers from Solid to just be out in the community and connecting with folks, to connect them to care, to connect them to Safe Supply. And that's been really helpful as this project gets up and running in terms of figuring out what's working for folks in the community and what still needs to evolve. So that sort of reconnaissance information has been incredibly important in sort of the ongoing development of this new team and the new model. We've been hiring and getting the team together and doing orientation so that the team is ready to get up and running this fall. We've been doing, working with our community partners at Solid and also the Canadian Institute for Substance Use Research to do some service user design. We're engaging in focus groups right now, and really planning an ongoing evaluation plan that's going to be engaging with people with lived experience, people who are getting pharmaceutical alternative scripts, so that we can have a continuous feedback loop and information from them, ways for them to be involved. Yeah, so the SAFER project is also part of a larger province-wide evaluation, which is a project of the BC Centre for Disease Control, University of British Columbia, Simon Fraser University, and UVic. That project is entitled Mixed Methods Evaluation of Risk Mitigation Measures to Address the Dual Public Health Crises of COVID-19 and Overdose. And so that's a province-wide initiative to engage, again, with folks who are receiving pharmaceutical alternatives under the risk mitigation guidelines, to determine what's working and what's not. So we're part of that project, and also our efforts for research and evaluation are focused locally as well. We, over the summer, did some community engagement with service providers as well. So some of you who are on the call may have participated in this, and we've put together a report. We're happy to share that report. And this was just a chance for service providers, outreach workers, nurses, doctors, pharmacists, to provide their perspective on what a Safe Supply project should look like in Victoria. And so you'll see some of the quotes here. I'm not sure if you can read them on the screen. Corey might be.
I'll give them a read. So some of the quotes that we gathered from our existing engagement. There is still an elephant in the room in addiction medicine that using drugs is harmful. It's not contradictory to harm reduction, yet the ultimate spirit is that we hope people will not use drugs if there is support. It's an uncomfortableness in the medical community that is not talked about. I've heard people talk about accessing safe supply and expressing their relief. Framing around COVID means that physicians don't know how long this will last. And this is one of the main aims of the SAFER project, is to separate safe supply from COVID-19. It's a shame that they were linked together as much as they were, because despite reassurance from the ministry that this is going to last beyond COVID-19, a lot of physicians are reluctant to get people on these medications if they think in the back of their head that in the next couple of months it'll no longer be available to them. You can actually generate a lot of harms giving people access to a safe supply and then pulling it away from them just a couple of months later. Another quote, "I've seen it be most effective in patients where there is a desire to get away from street use and want to get stable. Using safe supply to augment the OAT, opioid agonist therapy, seems to manage cravings and withdrawal and support them." One of my favorite quotes, "None of us physicians want to be gatekeepers in the system, so we are doing so reluctantly." And lastly, remember that ultimately when people use drugs, they generally want it to be fun and enjoyable experience while they are using them. Any barriers to the actual enjoyment of the substances are barriers to people using the program. And this is something that we've seen quite prominently out in community. People are being prescribed Dilaudid for their opioid use, but they're being prescribed enough to make sure that they don't go through withdrawal. They're not being prescribed enough to actually substitute their current drug use. And people take drugs also because it makes them feel good. And if they don't get that feeling, or if they can't go through the rituals of how they're going to use their drugs, they're not very likely to continue accessing those drugs. Stimulant safe supply in particular has been really wrought with a lot of concerns, because the alternatives that are being provided are Dexedrine and Ritalin, which are ADHD medications. Some folks who are gaining access to them, potentially the people who have undiagnosed ADHD or diagnosed ADHD, are finding this to be beneficial. But for the majority of people who are using methamphetamines on the street, they're using them for a number of reasons that include, it makes me feel good. I can stay up all night. I don't have to worry about eating because I'm living on the streets. And the drugs that are being provided as alternatives aren't meeting those needs. And so a lot of people who are being prescribed stimulant safe supply aren't currently having their needs met. Well, that's a lot of movements just to get back to where we started. There we go. Timelines. So SAFER is funded until the end of March of 2021, and we are actively seeking sustainability funding beyond that. We are going to be one of the projects that pilots nurse prescribing when it becomes available, and we're really excited that that's going to be part of our mandate as well. What we're calling Safe Supply Project here in Victoria is a prescriber light model. So we've actually already been doing a version of that where more assessment, more intake, more participation is put on the peers and nurses, and physicians act as an equitable team member in the decision-making process around provision of safe supply for people who are left unsheltered. We are actively seeking a new physical location to operate a publicly accessible OPS. That's been an ongoing concern for AVI for a long time. And because of COVID, our 713 Johnson location is not compliant with the necessary space that you have to provide in order to prevent infection. And so we're back to the drawing table and finding a publicly accessible site. And that's a huge need in Victoria, especially for people who inhale their drugs. There may be sites built out of the hotels, but those are just for residents of the hotels. We need a publicly accessible inhalation site and injection site more readily available here in Victoria. We are hopeful that we may receive new information soon from the province about increasing access to more pharmaceutical alternatives and increases in dosages. There's been some really promising talk about injectable Dilaudid. There's been some really promising talk about powdered fentanyl. There's been really promising ongoing discussions that have been going on for a long time about diacetylmorphine or prescription heroin, which is something that a lot of people across the country have been pushing for. And it seems like there's just starting to be a bit more buy-in from government to go down that rabbit hole, which is fantastic. What we do ask is that because this is such a new project, because it's growing its legs, we ask that everybody be patient with our project. We're doing something new that hasn't been done in our community and actually hasn't been done anywhere before. And so it's going to take a bit of an iterative approach. We're going to have to find out what's working and what's not working and then change again and continue to work with all of you to get feedback so that we can make sure that this is a model that really fits the needs of people who are currently really, really at risk for overdose in our community. As of September 21st, so this Monday, the SAFER team will go live. We will have 5 days a week outreach with nurses, systems navigators, peers, and physicians. Outreach hours are between 11 a.m. and 3 p.m. Monday through Friday, but we basically work 9 to 5. We have a dedicated phone line that you will be able to access, and that number is 778-677-SAFE. We have cards that we'll start handing out starting on Monday. Maybe I can get Heather to type that number into the chat. And we'll be able to also provide weekend coverage. So there's a nurse and a physician through the SAFER team that will be available for telehealth support on Saturday and Sundays and stat holidays. And that also will be between the hours of 11 a.m. and 3 p.m. We won't be doing new starts, new intakes over the weekend, but we'll be able to help support people if their prescription has run out or if there's an issue accessing at the pharmacy, we'll be able to help support them and troubleshoot those issues with them. We have a really great team. We've just finished doing our orientation with everybody. We've got some excellent nurses. One of them has joined us on the call today. Katie, we can see now, has joined us. We have a really cool team, and we're just really excited to be working with all of you and finding a way to integrate ourselves into the existing inner city services so that you know how to refer to us, you know how to reach out to us, and we know how to reach out to you in a way that's supportive mutually. And as I've said, we wanted to reserve the bulk of the time here in order to provide question and answer period. I know a couple people type some questions into the chat that we'll be happy to start off with. Yeah. Chat master Heather.
So I think there's one question about one of the quotes in the chat, and I'll maybe get you to have a read of that, Corey. But otherwise, folks can unmute yourselves if you'd like to ask a question or make a comment verbally, or feel free to enter something in the chat if you'd rather there.
Interesting third quote box is from clinician is self-contradictory in that advantages are also ostensibly the goals of OAT. What was the person being quoted was implicitly saying? Can you, Russell, are you with us? Can you?
Yeah, it's really a kind of inconsequential thing. And the presentation was great, and love the objectives of your project. But yeah, if you read that quote,
I'm gonna get to it now.
You're gonna make us all queasy.
Is everyone getting seasick as I take you on that journey with me?
So using safe supply to manage cravings, withdrawal, and support are actually the objectives of OAT. So implicitly, there's an underlying clinical statement in there that OAT is insufficient.
Yeah, I mean, so that the reason why we include these quotes is not to say that they 100% support exactly what we're doing right now. We include them because that's what the engagement process has shown us to date. And so right now, one of the biggest issues that we've encountered with Safe Supply is that it is being conditionalized with OAT. And while that works for some people, it also doesn't work for other people. And there is a clinician mindset with a lot of the medical community that safe supply needs to be offered as a means to manage withdrawal and get people off drugs. And many people just aren't ready to stop using, but they still deserve access to safe supply. And so part of the SAFER project is to remove that condition of OAT being attached to every safe supply prescription because we need to be able to hit those folks who don't want to engage in formal addiction medicine treatment. Did I answer your question, or did I just go around about like a politician? Or
Good
a little
practice.
A little bit of column A and a little bit of column B. I think there is a couple of questions higher up here. Hi, Corey. Forwarding these questions from a colleague who is a nurse. What is the ratio, I believe is the intended word there, ratio of providing OAT safe supply versus only safe supply? So as it stands right now in Victoria, through the existing models, the majority of people have been offered safe supply alongside OAT. That certainly isn't happening in places, Russell, you could probably speak to this, certainly isn't happening as much in places like PHS, where there's options for people to access a site and things like that. But the SAFER project already has a number of patients who are on safe supply that don't include OAT by their request. There's some people who you even mention methadone or Suboxone or Acadian, and they get emotional because they've had a lot of trauma as accessing that system. And so we've already been able to make a shift away from those two being contingencies of one another. If you're looking for a specific ratio, I don't have that offhand. There's around 380 people on safe supply, according to the last numbers in Victoria. And I would say the vast majority of them are also on some form of OAT, if it's, of course, safe supply for opioid use.
I would say it is a vast majority of people.
Hi, Marion.
Give you the hi.
Well, anybody would know it'd be Marion Selfridge.
Yeah, totally. I'm doing the case series with all of the folks at Kool-Aid and Cameco, and my students also went to PHS. So we're in the process of reviewing to look at outcomes, especially whether people have stayed on OAT and if they've stayed on their PPRM. And I'm only about 90 people in to that like group of over 300 for us. But I would say the vast majority were offered or were already on OAT, and a big chunk were offered at the same time. And so it does, and there's been lots of discussion amongst the clinicians about having the two go together. And
arguably there are times when people do benefit from those two combinations for sure, especially when it comes to the fact that the Dilaudid isn't doing enough to last the whole day, and you know, having OAT as a backbone there will help people not go through withdrawal in the middle of the night, decreases overdose risk if there's periods, peaks and valleys of use. But in my mind, it shouldn't be a hard set requirement. And if it's not patient-centered, if it's not person-centered, then it's not really harm reduction.
Yeah, absolutely. Yeah, I'm just looking to see that in that group of 300 people at the clinic, that we had done some evaluation with 276 of them. It's sort of this ongoing process as we're figuring all this stuff out. And 48% of them were on opioid agonist therapies already, and 34% were added, and only 19% no. But that doesn't sort out the people who are only taking a stimulant PPRM. So I would think that the variety of those would be there.
My goodness, I have to ask, when is there going to be like a public report available for folks about? It sounds like you're getting some really great data that would help them practice across the province.
Yes, absolutely. So the goal is to create a report as soon as we have completed the full round of reviewing the like outcomes, because we've been trying to collect outcomes at the sites, especially with there's a form that the nurses are filling out with patients. It's just asking about like the benefits of this. And then again, those like, you know, is there a documented overdose? Have people stayed on, or were there breaks in terms of their access? Were there positive or negative things that have happened to them as a result, or, you know, possibly as a result? And definitely that connection to OAT, as well as just a whole bunch of numbers about who folks are and what other things are going on for them that's been documented in their charts.
Yeah, I mean, I think you just touched on a really important piece here, and that's about metrics for success when it comes to safe supply too, right? Because we don't have much evidence or data on this brand new initiative, we kind of lean back on addiction medicine outcomes, which focus a lot on things like treatment retention, follow-ups, urine drug screens, those types of pieces. And so What are your thoughts in order to develop other metrics that are individualized, like the less tangible pieces, like I feel better, I feel more stable, I'm able to have better relationships with people? How do we measure those pieces too?
So, I mean, for us, it's all about just asking people and seeing if it gets recorded in the chart, which is, there's a multiple different things going on there in terms of just clinician interpretation and my interpretation as well. But I have, would definitely the decreased illicit drug use, that is sort of one obvious thing that people are looking for in a variety of ways that, and hopefully that's that they're getting what they need. So the other positive outcomes that I have so far written down here are decreased cravings. And I would say as well that this is this combination of all of the people who have now been housed, if not marginally or whatever, but within the sites that we have now in Victoria, through the Hojo and Travelodge, etc. So there's all the things that are happening just because people have a bathroom and a shower and a bed and and care in a variety of ways. So I would say that there because a lot of the people are housed in those sites, that there's a connection between. But other things I have are healed wounds and wound care, because so many folks had cellulitis or have cellulitis, reduced money spent on drugs, sleeping better. We've had a huge uptake in Hep C treatment. We've started a whole bunch of people.
I was hearing about the numbers out of the hotels. It's pretty remarkable how
it's
many.
Amazing, yeah, for sure. I'm trying to think if we started 11 people in August. And the vast majority are folks that are staying in hotels in the months before that. And we found people that we had tested at Rock Bay Landing and then hadn't been able to offer treatment because they just weren't in a space ready to do that. And now that they've got a place, we've been able to offer treatment or even just find blood work from people who had finished it already. Increased emotional stability, increased uptake of PWD applications, which has been a goal of the physicians and nurses as well, to identify. And I have a list in mind about whether or not we know if people have a PWD or not, just to give them that extra, such a small amount, but some extra money and the other stability can come with it. And then good or bad, increased engagement in medical care, something else that I'm commenting on, because definitely there's been advocacy and just a lot of care going on for specific people. And some of the physicians are talking about that as well in terms of possibly increased trust. So for some, this is a struggle, especially with just feeling like, these are not patients that super well, and suddenly you're forced into this situation, having these discussions back and forth in that same kind of addiction medicine model. And other physicians who are like, this is my way in, that I'm actually having good, real, honest conversations with people about their substance use, and then be able to connect to HIV care or, addressing trauma or other things as well. So lots of possibilities there. Yeah.
Fantastic. Thank you so much for sharing that, everyone. Only Marion can just be called on the spot and give a informal presentation on evaluation metrics for Safe Supply. So tip my hat off to you.
I've learned a lot in the last couple of months when Chris Fraser just emailed me and said, could you make a database? Make me an Excel spreadsheet, Marion. Okay. Yeah, there's 300 people now and 400 people through Cameco, both people who are living in the sites and are in the arena, and the ones that are the Dr. D. So I can see, for example, August 18th, you and Ash or Fiona went out and met a whole bunch of people in a Dr. D way, right, to try to offer PPRM. So
we got 8 people started in one day, and I think I burnt out Ash in a single day.
And not a lot of, I have to say right now, all the ones I've read so far, not a lot of people stayed on or even accessed, right? So again, we have this thing of are we offering what people need and want? Are they even going to bother to move forward, to go to the pharmacy? Is this what they need? Can they just buy the same things for, really cheap on the street to not have to access any other people that are going to increase their trauma or feeling surveyed?
And that's part of our, that's the previous month. So now that the team's actually getting started on September 21st, prior to that, what we've really been doing is finding out those kinks in community, right? We can get people a prescription for Safe Supply, and they're sleeping in a tent across from Rock Bay, and their pharmacy is literally up the hill.
Literally, right there.
And then we can follow up with them 3 days later, and they still haven't made it there for a number of reasons, ranging from the chaos of living on the streets and being displaced constantly, to it also just clearly not being enticing enough or the right fit for that person to want to continue to go to those places. And so that's been really like part of the last month and a half for SAFER, has been figuring those pieces out so that when we start out on Monday, of course, it's going to continue to happen in some way, shape, or form, but that we've got some strategies in place so that we can get people through those first couple of trips to the pharmacy, so that we can get them to keep trying and working with us, so that when the dose doesn't work, they don't just stop, but they connect with their care provider and we find a way to get them more, or maybe change the drug up that's required. And so, yeah, it's been a really great eye-opening experience about what the realities are of safe supply, particularly for people who are unsheltered.
Yeah, the
Cool.
question there from Nick.
Yeah, there's just a couple more here that I'm gonna, any insight into backlash or complications from disrupting local supply networks, i.e. frontline dealers. There hasn't been any of note on our end that we've noticed at this point in time. Any concerns about providing safe supply to people who are also frontline dealers? Frontline dealers also use drugs. Frontline dealers are also at risk of overdose. Diversion is clearly something that a lot of prescribers are fearful of. And of course, we want to make sure that drugs that people are prescribed are drugs that people will also use, that the person who's prescribed will take the drugs that are prescribed to them. But just because somebody is a frontline dealer does not eliminate their candidacy to receive safe supply. And we need to really shift away from some of that paternalistic thinking, because a lot of frontline dealers are not very different from the people they're dealing with. They've just found a different strategy in order to make ends meet.
Corey,
Yes.
can I jump in here with just a follow-up question with Marion while we're close to that piece that she just
Absolutely.
presented?
I'm going to try and catch up on these messages on chat. So
Okay,
And I
great.
have to go in 1 minute. I'm supposed to be teaching a dance class in 16 minutes in Beacon Hill Park. So,
So Marion,
please.
my question for you is, when you mentioned that there's a metric around decrease of illicit drug use, I'm wondering if there could be a sub-metric that could go alongside that where someone may indicate, no, there hasn't been a decrease, and noting that we're trying to apply this medicine and access through a public health approach versus an addictions medicine approach. Could there be a sub-metric that asked about any positive changes to the continued use of illicit substances? Because I wonder if with stability on a medication that meets primary need, that people may find room for more benefit and value of other illicit substance use.
Yeah, interesting. So I think that the clinician team that has created the document that they use are thinking about how they can adapt it. I see Courtney on the call as well, and she is definitely someone who is trying to capture similar information through the PHS patients, just in open fields about, what people are saying. And both of us are limited about the fact that we're just writing down things that people are saying in people's charts, or they're filling out in a form, versus doing qualitative interviews. So I'm going to be the person who's doing the qualitative interviews from that larger project that Heather talked about. That's the Mixed Methods project. And so I'll be doing at least 20 qualitative interviews with people who have tried to access or are accessing these prescriptions across the province. And so I really think that that's a great way of framing that I'm going to take a note about and talk over to make sure we can think through what that actually looks like and how we could ask that question as well. Again, for what I'm doing right now with this chart review, it's just, I get to write down what people say in people's charts. So it's, there's only so much that happens there, and I can help to try to influence staff to be more fulsome in their conversations. But I think it really is in those both quantitative and qualitative actual discussions with people who are using that we'll get better information in that way. Does that make sense?
It does. Thank you so much.
Yeah, thank you.
Thank you, Marion. I really appreciate you being here, and I'm super jealous. Can I come for the dance class?
Yeah, we're gonna go meet at Mackenzie or whatever, the baseball field. I'm gonna go right now. So join us.
See you there.
Okay, take care. Bye-bye, everybody.
Bye. This question's from Nick. Maybe this question was addressed already, but have you seen many or any instances of safe supply that people are accessing, meeting their needs or desires enough to reduce or cease altogether their street drug use? My answer is yes. Not as many as we would like them to. Out of the, for the last month and a half, it's been myself and Katie with a binder trying to help people in unsheltered locations, and so it hasn't been perfect. But we've got a certain percentage of our patient cohort who, even folks who are using stimulant safe supply, who are reporting feeling more stable, who are having more access to the healthcare system, who are connecting and finally getting much needed blood work done and other diagnostics done because they feel more stable. We have folks who are on opioid safe supply who are reporting reduction in illicit fentanyl use. And we even have a couple of people who started out with us in unsheltered locations and still call us from their house now that they have been housed, asking to make sure that they can stay on their prescription. And they're feeling so much better and reporting feeling stabilized. Now, I have to add the caveat that it's still not good enough. It's not where it needs to be. It's not meeting the vast majority of people like we would want it to. And that means that we need to continue to be flexible and to adapt our approaches instead of just kind of resting on our laurels on an existing system that's clearly already quite broken and not meeting folks' needs. Let's see. Russell, diversion is harm reduction. You said it. I wanted to say it, but you said it. Thank you for answering questions that put forward by colleagues. Oh, okay, we're out of questions. Does anyone want to ask questions out there? Bernice, I see you've got both hands up.
Yeah, I actually have a comment. I brought a group of my community members to an event at ABI. I believe her name was Brittany Barker. Heather, do you know who she is? Anyway, she's currently working with FNHA. And so what happened is that at that particular meeting was my community sat there very quietly. They did not engage, they did not respond. And it was a challenge for me because I know historically that that's the way, not all, but the majority of the Indigenous homeless community respond when they're in a room full of, non-Native people. So I shared that with Brittany. And so what came out of that was actually FNHA has, so I guess historically FNHA, I should clear this up first, FNHA has always been on reserve. They're just now coming off reserve, and they're actually now starting to work with the people that live in urban environments. So that's part of the history of maybe why it's taken so long to get here. But anyway, my conversation with Brittany was around how my community didn't engage. So it took many, many months. But FNHA was here about 2 weeks ago, and I actually brought 4 members from my community to a workshop to talk about how the fact that there's nothing remotely resembling anything that deals with Indigenous. What does it look like? What services do they need? So, I think that's really huge, and it has to be noted, and we have to look at how are we going to make that work. Somebody's at my front door. I don't know who it is. Sorry. They'll come back. But anyway, so that's a conversation that we need to have as well. I know it's going to be an ongoing conversation, and it's going to take a long time, but I appreciate it that it should be part of our how are we going to work through this with the Indigenous homeless community. Thank you.
Thank you.
Thanks, Bernice. I think that's a really important point, and I really appreciate being in touch with you earlier this week too, to sort of sort out how we can really make sure that the focus groups that we're conducting for SAFER include Indigenous voices. So that's definitely something that we're we're glad we're working with you on, and we have to get your door there. Just to say too that the larger provincial evaluation project, the one I mentioned earlier around pharmaceutical alternatives, there is a consortium that is meeting monthly, and I know that FNHA is on that invite list, but I also am aware that you know, anyone who's sort of working on these topics, I think has been invited to join that consortium, and so I can connect with you after, Bernice, if that's something you're interested in. I realize you're not advocating for more meetings here, but that is another place that if you wanted to link in with the work that you're doing here locally, that could be a place to link in as well.
Consortium. I've been calling it consortium.
I think you could say either.
What an idiot, Corey. Any other questions, comments? Feel free, now is the time.
Corey, this is Griffin again.
Hey, Griffin.
Hey, I just want to acknowledge I really appreciate the ethic of way you opened this call and everything that has gone into this project. You know, and specifically, I think, you know, that reframing and repositioning, and I think it's so appropriate that this is being viewed through a public health and a harm reduction lens versus an addictions medicine lens. I see that as being a significant barrier. So just holding my hands up to you all as a team and everyone that's been contributing to this. It's such important work. So thank you for that. And then just practically, I've been really focused myself around utilization of illicit drug toxicity, deaths or incidents, or thinking about things in relation to being drug poisonings and not necessarily utilizing that word overdose so much. And yet I noted it kind of throughout. And so I just wondered how that's come up in conversation and like the intentionality of that within this project, if you could share on that.
Yeah, I mean, absolutely. When we're speaking with a group of people who are, you know, in this field and working, I tend to use the language of poisoning. And when we decided to open this presentation up for the general public, I leaned a little bit back on mainstream terms just for relatability and for people to be able to jump onto the language. But I take that note, and I also acknowledge that it is important to even if people are unfamiliar with those terms, to start familiarizing them with those terms, because you're absolutely right.
Yeah, and it really was just me just trying to stay in step with maybe what some of the people with lived experience have been contributing into this project and how you're utilizing that. So it wasn't a critique by any stretch. It was me just trying to continually aligning myself with emergent work and how people are doing that. So thanks.
Oh, absolutely. I didn't take it. I don't take it personally at all. I actually, I eat critique for breakfast. That's the only way that I grow and learn. So I'm happy to take it fully. There's no fragility on this end. Is it possible to speak a little bit about pharmaceutical alternatives you'd be offering outside of existing guidelines, or is that still to be determined? The answer is yes and no. So obviously things like powdered fentanyl, injectable Dilaudid, some of that stuff is going to take time to develop protocols for. That's pretty out there for community distribution, especially. It is happening, you know, in some microcosms in more controlled settings, IOT settings, housing settings, but for community distribution through community pharmacies, it's quite untreaded territory. But starting in October, when it comes to opioid safe supply, we will be adding oxycodone to the list right away as an initial option for people. So, you know, right now it's being offered if Dilaudid's not working for people, if they have allergies or adverse health related incidences related to MS-Elan or Dilaudid. But starting in October, it'll be one of the 3 initial things that people can opt for when they're being offered safe supply. And then moving forward, when powdered fentanyl is available, we'll be developing protocols to make that available for people, especially folks who smoke their drugs. When injectable Dilaudid is available for community distribution, we'll be going down that pathway too. But it's about balancing the need to push for these things to happen now, but also for them to happen now and safely for everybody. And so we have a really great group of doctors who want to go down that road, who want to get there, but they want to do it in a way that's, not going to require them losing their medical license in the first month of the project as well. Griffin, you unmuted. Do you have a question or comment?
I did. I was just curious, noting the feedback across the province from people who are getting offered tablets that aren't suitable for injection and that could come with, unintended consequence and harm. I'm wondering, is this project utilizing, wheel filters or other kind of harm reduction supplies to manage some of that?
Yeah, we actually, I don't know if Shay's still on the line, but we've got the steri filters available now, which are much more effective when it comes to filtering out pill particulates and when it comes to Dilaudid right now, people who are having their needs met with strictly through dose, if they're getting up to 24 or 28 tablets, whether they're injecting that or they're ingesting that, that's a huge pill burden on them, right? And there's a lot of things in there that outside of the opioids that could cause some harm to folks. And so we do make sure that we are integrating lots of harm reduction education in our safer supply starts. And that's really also where the peer part of our peer nurse-led model comes in, folks who can speak from an experiential standpoint and help people navigate some of this muddy water is definitely a primary intent of the project. 5 new messages.
The messages are all going to Corey privately.
Oh, it's like, what's happening?
I'm not able to manage those for you.
Courtney, I don't understand your question. Is there a service model happening within SAFER that you think will result in patients actually getting their SAFER medications compared to the challenges of patients getting to pharmacy to start and continue their medications?
Yeah, so I think this is something that Marion and I have really seen as a difference between the chemical and Kool-Aid patients versus PHS, where with PHS, we have patients living in housing with embedded clinical models where an on-site pharmacist actually delivers their safe supply to them every day. And that's really successful versus, I think, a number of patients that you've encountered in the encampments and sometimes even in the hotels, even if they go through the process of this medicalized model of getting their prescription, often don't actually start them or are able to continue them for various reasons, even if the pharmacy is just down the road. And so I'm just curious, I guess, if the SAFER initiative is going to have something that kind of addresses that.
Yeah, I mean, it's a bit of a moving target given the fact that people are chronically being evicted and displaced from one place to another, and some of those things are beyond our control. But Heather's doing a lot of behind the scenes work with pharmacies in order to try and see what we can do in order to address that particular issue. We also do work through SAFER in Souk, and we just got medication delivery set up at the Souk shelter. So we had the same issue with the pharmacies just down the road, and lots of people, we were finding out 5 days later, just weren't accessing their safe supply anymore. And so we worked specifically with that pharmacy, and now they have a nurse bringing people safe supply every day to them. And it's going to take a lot of individualized approaches to some of these issues. There's not going to be a one size fits all in order to help people. We also have funding in order to support people if they can't cover the cost of their medications, or if we prescribe something that falls outside of existing pharmacare coverage. And so we'll work with pharmacies to kind of set up a SAFER account so that if somebody comes in there and maybe they are freshly from a different province and they don't have coverage, that instead of them having to incur costs, it'll go directly onto our bill. And the same goes for medications that aren't already being covered under the mitigation guidelines. So my answer is yes, but it's going to take ongoing work. It's going to take ongoing troubleshooting and problem solving, but it's definitely something that's on our radar. You can't just, like 3-4 times, you can't just restart people and then find out, oh, they didn't pick up and their script is canceled. Let's get them started again. Like that's harmful to them as well, especially if they take a couple of days worth and then they go back to the street supply and go back and forth. The peaks and valleys and tolerances is the things that are going to lead to overdose. And so we can't just repeat the same thing over and over again and expect different results. We have to find out what are the systemic issues and try to address them.
There was a quick question from Rustus about the MySafe machine, and then I've asked that we start wrapping up for now. So just Rustus just asking if there was an update.
Yeah, I mean, I think Solid would be the most suited to do that. So Safer's work with the MySafe machine is like we provide support to it. It's not our primary mandate. So we are supporting Solid with MySafe. However, we're not like the primary operators for it. What I know is that the machines are here, but they're not currently being used. From my understanding, the staff still needs to be trained by the dispensing company, and there's been a bit of a challenge in getting that arranged, not to the fault of Solid. But when we do have more information to update, when we do have more information that we can get you, we'll make sure that that's part of our next kind of Safer update that we do.
All right, sounds, yeah, MySafe needs more funding, that's for sure. All right, I think we've got to wrap up, everyone, because people are starting to leave the call, and we've been here till just over noon. So this recording will be hopefully uploaded to the AVI Facebook page, barring any future tech difficulties, and we really appreciate everyone being on the call. If you're not already on our contact us, I think you are, which is how you got on this call today. Please feel free to be in touch with us at vicsaferproject@gmail.com. I will put that in the chat. And thanks so much, everyone. I'm going to stop the recording. Have a great day.